requirement that really puts in place for us to transition our members out of nursing homes or from a home into the least restrictive environment where they want to be. They have that freedom of choice. And so as Dania mentioned, yes, if the member comes first, the member has to have a desire. And if they don't have a desire, they don't even know that they can transition out, we certainly remind them and ask them, is this where you want to be? Or would you rather be at home with your loved ones, or would you rather be in an assisted living facility? And of course, the transition has to be a safe one, as Dania mentioned, for our members. And then as she mentioned, that communication happens, that assessment happens with that member, and then all those things are in place. Pretty much, we mirror what the contractual requirements are in terms of us getting our members out, but we don't leave out the fact that there's a lot of communication that happens with you and our care managers, our transition teams, and our members. If we can get them on a tour of the ALF, if we can get their guardian on a tour of your ALF, that's awesome. So they can see where they're going and they can be comfortable when they walk in. They've been there before. They understand the surroundings. We also have that obligation to see our members within 5 days because it is a change in condition, change in location. And it's a good way for our care managers to see how they're adjusting to their new surroundings, to see how they're adjusting from being perhaps in a nursing home, in an institution, and now having a lot more freedom than what they had before. And one of our managers mentioned on a call with us last week that she gets to see success stories every day, happy success stories every day, because our members, as you all know when you receive them, are very happy when they're in their own environment where they have some control. And as we know, it's the place of least resistance for them. They're healthier, they're living happier and healthier lives. And I think that's the goal of all of us with our members, is to make sure that they're in the best environment for them to thrive. And that's what we try to do with our members when we transition them to you.
Thank you, Lori. Humana?
I'm going to echo a lot of the process piece that United and Melina have shared. We also, one of the other components is really that partnership that we have with assisted living facilities. We have a lot of our members who have been in a nursing home for a long time and may have lost their apartment or their housing that they were in previous to going into the nursing home. So that's where assisted living facilities really have become really fosters those transitions and that partnership, because we can move people who have lost their community support into the community as a way to transition where they're having more freedom but still have social resources that are embedded in the community in the assisted living facility. So that's really one of the main reasons and one of the reasons that it's such a great partnership and to support our transitions in that assisted living facility and the adult family care homes as well.
Thank you. So at this time, thank you panelists, I'd like to invite Dee Dee to come up and begin your presentation if it's convenient. Thank you.
All right, good afternoon, everybody. I'm going to talk a little bit about a couple of topics this morning. One of them is something that's probably already on your mind, and the other one is one that will soon be on your mind. We'll start with the one that will soon be on your mind, though. We'll be touching bases on the home and community-based settings rule. That we have some new activities coming up with that very soon, and then we'll finish up with patient responsibility for recipients and assisted living facilities. So first, home and community-based settings rule. How many of you are familiar with the home and community-based settings rule? All right, so there's at least a few, and the rest of you are probably too sugar-laden from that gigantic Rice Krispie treat to raise your hands up, right? So HCBS services allow recipients to receive services in their own home or community instead of in an institution. The HCBS settings rule was developed. My first experience with it was in 2012. They were in the process of rule development at that time, and people from Centers for Medicare and Medicaid Services came down to Florida. We were just starting and rolling out the long-term care program. They went with us on a tour of a number of different ALFs in the Orlando area, and kind of talked us through what their mindset was about the home and community-based settings rule. Fast forward to 2014, and the rule was finalized at that point. And then in 2015, we implemented a provider self-assessment. So the agency did quite a bit of training showing that really intensive tool. Providers did a self-assessment that they submitted. And then we developed from that a statewide transition plan that talked about what, I'm getting a beeping. A statewide transition plan that talked about what we would need to do to come fully into compliance. That takes us up to what's coming this year, where we're going to be going back, revisiting, and actually checking to see which facilities are compliant with the HCBS settings rule. All right, I'm one behind already. All right. So with the HCBS settings rule, this is a federal rule. It allows people to have access of setting where they can have a choice of living in a place that meets these kinds of characteristics or has these qualifications. The first one is access to the community, being able to go out, be involved in community activities, whatever those activities may be. A freedom of choice when they're choosing a setting of where to live. So I want to live in this place or that place. They have some choices about within the facility of the kind of room that they may have, roommate they may have. Safeguarding their rights to privacy, dignity, respect, and freedom from coercion or restraints. Optimizing their independence. And then a choice of services and providers. So while the person might choose to live in an assisted living facility, they still have the ability to choose different providers. Not anything like a nursing facility where you have people who come in and they're the people who serve that facility. You have a greater choice in the setting. And then the last one, if it's a provider-owned or a controlled residential setting, it gives people the same kind of privileges that they have if they were a tenant living in the community. They have the right to notice and those kinds of things. They have the option to choose to live in a private room if they can do so. That's, we all know that you may not have the resources to be able to choose to do that, or maybe you have to find the extra resources to do so, but it's a choice that they can make. They have control of their daily schedule. They can choose whether to participate in activities or not. Unrestricted visitation, that was one that I remember being important to CMS, is that something that people have the opportunity to have others come in from the community and visit them. And then that it's physically accessible, of course. So these are all the settings where we will be taking a look at home and community-based settings characteristics and whether or not these are meeting the requirements of a home-like environment. Some of these you don't necessarily think of for adults, foster care homes. This is a rule that applies to both adults and children. So it's going to be used across a variety of community-based settings. So in the coming months, the plans are going to start compliance reviews of these different settings, and they'll have extensive training on the rule, the tool that we'll be using to assess compliance, and then the agency's expectations, what exactly they need to look for, and the end goal that we're looking for. And of course, during that time, we'll have a high level of communication between the plan and the agency to make sure we're all on the same page. Based on the assessment results after that, then settings are going to be characterized into one of the following categories. They're either fully compliant with the rule, they're non-compliant with the rule and they need a plan of remediation, or it's a setting that's considered presumptively institutional. Now, presumptively institutional is the one we're going to focus probably the most on. The second one, there may be some deficiencies, but it can be remediated fairly simply. All right. So when a setting is presumptively institutional, they're looking for some particular characteristics. For one, it might be in the same building or on the same grounds where there's an institutional setting that's located. Now, being located in the same building or on the same grounds does not necessarily in and of itself mean that it's absolutely a no-go and it's institutional, but there are some questions to be asked and answered to make sure that it's still a home and community-based setting, that it is a home-like environment. We'll also be looking at whether the facility has the effect of isolating people who are receiving Medicaid home and community-based settings from the larger community. I think we talked on one of the earlier slides that the goal is for this person to be able to be involved in the community to the fullest extent possible. All right, now once all of these assessments are completed and that information's pulled together, the settings that are preliminarily identified as potentially meeting presumptively institutional characteristics are going to get a copy of the written findings from the plan, and they'll get a copy of the assessor's completed report. They'll have a chance to provide extra information that shows that they're not an institutional setting, or a chance to come into compliance. So kind of similar to that second category, there are deficiencies that are identified there, but they do have the opportunity to remediate those. Now, settings that are not able to come into compliance, settings that are deemed presumptively institutional and don't come into compliance, it is required that the state terminate those settings from the program. However, the good news is this is largely within your control. You'll have all of the tools that you need to determine if you're a setting where it's presumptively institutional and what needs to happen in order to bring that into compliance. And I'm sorry, I really do wish I remember the numbers, but I do recall from discussions about the earlier assessments that there were not as many presumptively institutional settings as one might have thought. It was a fairly small number, so this is good news. While there may be other facilities who need a little remediation, presumptively institutional is pretty isolated. All right, so if you have questions about that, we'll direct you back to your long-term care case manager for any of your recipients' plans. If you can get additional information on the home and community-based settings rule on the agency website, I believe we even have some of our previous PowerPoint presentations still posted, so you can get a good overview of what that is and what it means for you. Now, one that I know has been a topic of discussion, patient responsibility for recipients living in assisted living facilities. And I'm going to mostly go a little bit over kind of how this comes together, how that gets determined. And I think that we have some other questions that come up for the panel today where they'll talk a little bit more about those aspects, other aspects of patient responsibility. So what is it? Patient responsibility is the amount that an enrollee needs to contribute toward the cost of their Medicaid long-term care services. DCF determines this. They do that based on the recipient's income and the person's choice of residence. Now, when you come into a waiver, if you're as a recipient, if a person comes into a waiver like they would in the long-term care program, they have higher income and asset limits. So they aren't meeting the traditional Medicaid income and asset limits. They may have a little more. So this is where patient responsibility starts to come in. There are a couple of terms, and sometimes I think I hear them used interchangeably, but these don't mean the same thing. There's patient responsibility, which is that amount that the recipient is paying toward the cost of their care. But then there is share of cost. And share of cost, when you think about that, you want to associate that with medically needy. That's somebody who meets so many of the criteria, but they don't yet have full Medicaid. They have more income and asset limits, income and assets than what would traditionally be the case. And they have to do a spend down before they can access full Medicaid. So share of cost is medically needy, and share in cost is your home and community-based settings folks and their patient responsibility determination. So as I told you, DCF determines patient responsibility. DCF is the only entity that can determine patient responsibility, and that's even for people who have Social Security income. They have a process, they've got a rule, and then there's also federal rules that also regulate how patient responsibility is determined. They have some good tip sheets on their website I'll point you to if you want to understand how the sausage is made a little bit better. Now, the key components of patient responsibility when you have a SMMC long-term care enrollee who's living in an ALF, the key pieces are their income, their personal needs allowance, and their uncovered medical expense deductions. So I'm going to talk a little bit about personal needs allowance and uncovered medical expenses, oftentimes also called UMED. So the personal needs allowance is the amount DCF calculates that the person may keep to pay for their personal expenses. And that amount is made up of the monthly room and board rate for the facility where the enrollee is living and 20% of the federal poverty level. That changes each year. I think in my slides I had 2016 as an example, but you could look up a federal poverty level amount for 2019 and kind of roughly do the math for yourself as well. So here's an example. Let's say this person lives in an ALF and they have a $1,500 monthly ALF basic room and board charge. Add to that 20% of the federal poverty level. In this case, it was the 2016, and you'll see this is their personal needs allowance. In this case, it's $1,698. There's more math involved, though, not to frighten you away. So what is an uncovered medical expense? Uncovered medical expenses occur when the recipient incurs a charge for a medically necessary service that isn't covered under the Medicaid program. DCF will ultimately reduce that personal needs allowance by the cost, by any unmet medical expense costs. And those are your UMEDs. These can be premiums, deductibles, or co-insurance charges for health insurance, or they can be other medical expenses that are approved by DCF. A question we sometimes hear is, what about the ALF room and board charge? The room and board charge itself isn't considered an uncovered medical expense, so it's not counted in UMED. Now, DCF can adjust this patient responsibility amount. If the person's UMED goes up, they have more medical expenses that aren't covered in a month, then the patient responsibility would go down. If the person came into somehow more income, then their patient responsibility would go up. Or, vice versa, if their income went down, their patient responsibility would be reduced. So how does DCF use the personal needs allowance to calculate patient responsibility for somebody who is in home and community-based services and resides in an ALF? To calculate the patient responsibility, DCF is going to reduce their total gross income by the amount of their personal needs allowance. So for example, this person may have a total monthly income of $1,750. Now, you remember that previous math problem we did? We took away the $1,500 for their ALF room and board charges, and the $198, which was the 20% of the federal poverty level, and now we're left with this person has $52 in monthly patient responsibility. That $52 is the amount that they're expected to pay toward their long-term care costs. All right, so health plans are responsible under the contract for collecting the patient responsibility for somebody who may have MMA or LTC benefits. However, the health plan can transition that responsibility to its contracted providers. We have some provisions in the contract that give them some directions on what they should do. So you would see that in your agreement with the health plan if you as a provider were responsible for collecting the patient responsibility from that enrollee. All right. How does the health plan collect the patient responsibility? If they're delegating the collection of patient responsibility to the provider, in this case the ALF, we have the monthly rate for ALF services. This would be assisted living services in the long-term care program, or it could be assistive care services if they're in the MMA program. And let's say that amount comes up to $1,200 in a month. Take off of that the $52 for patient responsibility, and the plan would pay the ALF $1,148, and the ALF would collect the $52 in patient responsibility from the recipient. If the plan doesn't delegate that to the assisted living services provider, then the plan would pay the ALF the full amount, and the plan would collect the $52 patient responsibility from the enrollee. All right, so there are some instructions on how to find this information on DCF Provider View. For nursing facility services, the agencies managed to automate that so that amount and those updates that occur come across, and that information can be provided to plans automatically. We still have some work left to do to accomplish this for HCBS enrollees. So for assisted living services, for folks living in an assisted living community, the source of truth in this case would be DCF Provider View. That's the source of truth for both you as an ALF provider and for health plans as the insurer. All right.
And Dee Dee, just as a follow-up, it is correct when we talk about assessments, future assessments, that plans will be involved in working in. Of course, all of that relates only to ALFs that are serving Medicaid recipients.
Yes, that's right. Okay. So if you're an assisted living facility serving a Medicaid recipient, you may be involved in the HCBS characteristics assessment. Mm-hmm.
And also, just so you know, today is Dee Dee's birthday. So, now, was it Lois who was the young lady who sang for us earlier? Lois was it with Ullman Bursa? Mm-hmm. Is that who it was? Mm-hmm. Is she in the room? Darn. You know what I was thinking. So we won't inflict our singing on you, Dee Dee. So there you go. But if she were here, we would pull her in. All right, so let's go ahead now. Since we talked a good bit, and thank you about talking about the personal needs allowance. I want to talk a little bit about billing processes, but really kind of in a way that really connects with our audience here. So we're going to start with, or let Arlene field this for us, Arlene with Simply Healthcare. And so Arlene, what are the most common reasons for non-payment or delays in submitted claims?
Some of the most common reasons for delay in payment would be improper procedure codes, wrong listing modifiers or not listing modifiers at all, member information not being accurate, or member eligibility not being verified prior to submitting the claim, which then turns around with a denial in payment because that member is no longer with that specific plan that they're billing for. And you said delay or?
Either the common reasons for non-payment or delays in submitted claims. And then I also wanted you to address when that does happen, what's the expected flow of communication?
So with assisted living facilities precisely, we do have a dedicated provider relations unit who the claims team with Simply advises the PR rep of any, let's say, claim denials or rejections, and then that PR rep reaches out to the ALF administrator to let them know. And oftentimes it's something such as a missing digit on that claim that was submitted, and they just need to resubmit it, or a missing signature, an NPI number. So really it lies between the claims department, the provider relations rep, and then that communication back to that ALF administrator. I wanted to also bring up another reason of delay or denial in payments is duplicate payments. Many times a provider may submit a claim and not get paid for that claim, and it could be because of a missing digit on an NPI number, but when they go to resubmit that claim, they don't submit it as a corrected claim. So our highest level of denials is based on duplicate claims, because when they're resubmitting, they're not coming in as corrected claims.
Thank you. And I'd like to move now to, it's a bit of a related question, and I'd like to pose this to our representative from Florida Community Care to talk to us a little bit about your recoupment process. And again, what is recoupment? What is recoupment? And how does it fit into what we've talked about? And then how do you communicate that when you have recoupment issues to the ALFs?
So I'll kind of start this by picking up a little bit on the billing comments. I mean, our mindset is that we got to make billing as really as simple as possible for folks, right? You guys are aware the rubber meets the road. Even if we carry the absolutely most easiest process, and we're on our way, hopefully, to doing that, right? It's not going to be understood if we don't communicate it well. So I think a thing that you're going to hear is kind of communication. Are we talking to you? Are we letting you know how it works? Or are we letting you know how it goes? Probably no area where that's more important, I think, than in recoupment, right? It's the same thing. Are we talking to you? Or are you telling you about the issues? There's a couple things I think I wanted to key on Dee Dee's presentation that you heard, so around patient responsibility. The first is it's not automated at present time on the HCBS side, right? Literally all of us get stacks of letters coming in from the Department of Children and Families, right, to go through and kind of manage this. So again, we've got to be talking and working together about these cases and the information that's flowing, because it's not flowing very well. Definitely an opportunity for improvement there. But you probably also notice that it changes, right? It can change monthly. Multiple times actually, can change retroactively, right? So again, we've got to be talking and sharing information about what the current status is and working together on that. We've always seen retroactive is an issue for recoupment. I was talking to someone last week about some eligibility cases where their eligibility was going back. Date of death has always been an issue, maybe more so depending on how your payment arrangements are structured with plans. Now we're seeing probably more so, again, a lot of retroactive or gaps in eligibility, particularly given the new contracts in the structure between MMA and long-term care. So again, all of this is kind of coming from the eligibility work that flows out, again, with all those letters that you see, that we see. But again, I think it's communication. Make sure you understand what your provider relations folks are saying, care managers, that they understand this. And it's not only what we're telling you, but it's also what we're sending you in writing. I mean, we've already experienced that in the short time that we've been operating since the rollout in December, the opportunity to really refine our communications, our written communications, in a way that makes more sense. You can see just how the language, share a cost, patient responsibility, right, can create some confusion. So again, opportunities for improvement. If there's a way we can communicate better to you, please let us know.
Thank you, David. I'd like to move to Sunshine now with a question. We're going to switch gears a little bit. And Donna, if you're ready, if you could talk to us a little bit. We want to talk about case management with clients who are residing in assisted living facilities. Specifically, just kind of break it down for us. What should assisted living facilities expect to see, in their world, in the field, as it relates to case managers, interacting with clients, with them, if you don't mind.
Okay, thank you so much. How much time do I have? Because I could talk all day about this. So our case managers are the heart and soul of our long-term care program. Sunshine has over 600 case managers statewide, about 650 actually, and the case ratios are established by the agency in contract. So much of what goes on in case management. It's because it's defined in the contract. We all do it the same way. Case ratios are established for members who live in an assisted living facility. The ratio is 1 case manager to 60 members. That's home and community-based members. So keep in mind that the case manager has 59 other members in addition to the one that they're working with that day. What's also defined is the contacts and the contact frequency. So every member gets a new member orientation visit, which is that first visit after they've been enrolled in the long-term care program or with that plan. And that's when the comprehensive assessment occurs that Dana spoke of, where they spend, several hours with the member, and there are a litany of required activities that have to occur at that visit. Some that make sense, some that don't, but they're all required. And it is a personalized, person-centered visit where a care plan is created. It may be done at the time when they're in their nursing home, it may be done in their home, it may be done once when they're in an ALF. But if they're in that care continuum, you're going to see that visit if the new member orientation visit is done in your facility. Then after that, they are required to make contact monthly. The monthly contact can be telephonic. The problem is that many of our members cannot express their satisfaction with services over the telephone. They may not have access to a telephone in your facility. If they have a POA, the monthly contact can be done with the POA. But we have a rule at Sunshine, if we aren't able to contact the POA and the member doesn't have access to a telephone, they have to lay eyes on the member in the facility. And that may be the same rule. Plans may do it the same way. So you should see the case manager in the facility doing the monthly contact if they're unable to communicate with the POA. Then we are required to do a face-to-face visit quarterly. The quarterly face-to-face visit is to review face-to-face their member care plan, their plan of care. Again, their satisfaction with services. We update the assessment. We have to document any changes. We discuss their goals, their progress towards goals. So it's another semi-comprehensive visit. It doesn't take as long as the initial, but it's still face-to-face to update their plan of care and their assessment. We also do the significant change visit that Dana mentioned. If something happens, they go to the hospital, they're discharged, there should be a 5-day significant change visit if there was any change in health condition, new diagnosis, something like that. So ideally, you would see our case managers in your field, your facility often. If you don't, please contact me.
Thank you.
You should have a relationship with them. Also, I want to quickly mention we have a provider training team that supports the case managers. They're here and they support them when the case manager identifies that you have behavioral, general education, or clinical training needs. So we're happy to help you with that as well.
Thank you, Donna. I'd like to ask again in the same vein, similar to case management and what the caseworkers and what ALF should expect to see, Paul or Lori with United, if you'd like to just address that for a moment, if you have anything to add.
Absolutely, that was very comprehensive. So that was actually great. That is exactly what you should be seeing from the case managers that are in your facility. We do train them to make sure that they interact also with you, with staff, and make sure that they leave their business card. That's really important so that you have a point of contact to reach out and get a hold of that case manager for any questions, any changes in condition. Changes in condition can happen really quickly, and there are a lot of things that we could help to head off if we know about them soon enough. And we do really appreciate those heads up and things so that we can affect any kind of readmissions or anything like that. So in addition to that, I would just say that you should be seeing case managers, and you should know who they are, and they should be giving you those cards. So if they're not, just as was said, definitely let me know that. That's something we really do training the case managers on, and really pride ourselves in the rapport that they create with both the facility and the members.
Thank you, Paul. This next question, we're going to switch gears a little bit, and I'd like to invite Natalia and Ann from Humana to first tackle this. We know about that the ALFs have agreements or contracts with their managed care plan partner, and we know that ALFs go through something that they call credentialing. But what is the difference, Natalia or Ann, what's the difference between credentialing and the agreement between the plan and the ALF? How often does that credentialing occur? Who says what it must entail? If you could address that a little bit for us.
That would be me. My team handles both the credentialing and the contracting. So in order to be a part of the network and be a participating provider under the Medicaid or long-term care program, you need to go through credentialing to begin with. So that initial credentialing process happens, and you are required to submit your information similar to what CAQH requires, as well as an ownership form, your W-2, and that credentialing is good for a 3-year period. We will come out and do what is called a home and living evaluation study with you prior to that contract going into place. When we negotiate a contract with you, that contract is what's called evergreen, and evergreen means that there is no end term to that contract. We will have that contract go in place. It has an initial 1-year time frame, that during that 1-year time frame, for whatever reason, either one of us can term that agreement, but beyond that, it is evergreen. We work with you, with the provider relations representatives on a very regular basis, coming in, meeting with the DONs, understanding what's going on in the facility. Every time we need to go through re-credentialing, which is on a 3-year period, we will come back out again and we will do another home and living assessment. That home and living assessment is a requirement of the state, but it's also important because things can change. We need to know what's going on, what services you provide within the walls. That changes. You grow, you expand. And so that's an important feature of both the credentialing and the re-credentialing process. We also work with, the provider team works with the clinical team, because both of those folks are in the facilities that you own, so they share some of the best practices that they see or some of the issues or concerns that they see so that they can be addressed quickly. One of the things that we really stress related to contracting and credentialing is if you have a change of ownership, that you let a health plan know as soon as possible, because that has a very long-reaching effect related to your contract, your Medicaid ID number, and your credentialing. So the sooner that we know, the sooner we can work with you on that change of ownership and make sure that your claims are paid appropriately, as well as that you are aligned appropriately with the plan that you are affiliated with.
Thank you, Ann. I'd like to give Donna with Sunshine an opportunity if you have something else that you'd like to add related to the contracts and or the credentialing.
Well, I would say that I think we all follow the same credentialing requirements and re-credentialing. We don't make this stuff up. It's handed down to us from the federal government and Florida Medicaid. It seems like a lot of work and trouble, and it comes around every 3 years, but if you don't complete the application when it is sent to you and you don't follow the follow up on the contacts that we outreach to you, you will be terminated from the network. We cannot be caught by Medicaid allowing a provider to provide service that hasn't completed credentialing. So we take it very seriously. We're going through right now we just sent out about 600 re-credentialing applications for providers statewide, and we shake on our boots every time we're at 30 days and we have a list of providers who have not followed up. So we send it out 5 to 6 months ahead of time, and it's sent certified mail. We do multiple outreaches. At 30 days, you get a final warning, and we don't want to send it, and I know you don't want to get it, so please be responsive. And as they said, a lot happens from year 1 to year 3, so we just have to make sure everything is still current and active on your application. And we love the partnership.
Thank you,
So
Donna.
fill out the applications. Thank you.
Thank you, Donna. All right, so I'd like to turn now to David with Florida Community Care. Because we know that not everything works perfectly and we have difficulties. So we from time to time, so we have asked, and David has gamely offered to talk to us about Florida Community Care's provider complaint system. Why is it important, and when should people think about engaging with it, and what's the smartest way to engage with it?
So my boss, Lester Plana, has joined us in the audience, and he's going to kill me right now because as an operational person, actually maybe that's a little overstated. I would say love is a little too strong a word. I appreciate them. Okay, so let me put that in context for you. When we started training our provider call center staff, when we did the rollout, and we were going through some exercises as part of the training, and we, kind of say, what do you think about that? How do you code that? And and that's not a complaint. We'd say yes, it is. And they'd say, another example, that's not a complaint. We'd say yes, it is. We'd say if the provider's expressing dissatisfaction, we want to capture it as a complaint, because if we don't see it, we won't know it. And if we don't know it, then we can't address it. And we spent the rollout, as I'm sure Dee Dee and her colleagues did at the agency, looking at every single complaint that came in and to see what was going on with the program as we rolled out the program. Okay, I think you should expect, right, whether we have multiple ways, I'm sure most of the plans here have multiple ways, either again picking up the phone and calling, talking to your provider relations representatives, talking to your care managers, going on the web portal, however you get it to the plan. You should expect plans to capture that information and to read that information, to understand what you're saying, right? And to track that and to use it to, again, improve the program for all of us. The other thing that I would say about the complaint process, this is certainly true for us, is sometimes we come across difficult issues. Again, whether it's the eligibility issues that I was talking about earlier that are kind of difficult to resolve. You ought to always feel like you have the opportunity to escalate those issues. I know I talk to folks all the time, talk to providers about issues that come through as complaints, and we need some more information, and we've come across a really big issue. Like, what do you mean they have MMA eligibility but not long-term care eligibility anymore, and have really unearthed some very important things by that communication. I know Nestor talks to providers every day probably, right? So again, you ought to expect us to hear you, right? Anytime that, again, doesn't mean we did something wrong per se. If you're not satisfied, right, there's something that we can do better, and we ought to capture that. We ought to read it, we ought to take it seriously, we are required to report it to the agency, right? And we ought to talk to you about how we use that information to, again, make the program better for all the people that we serve.
And before we close, is there anyone else, any of our panelists who would like to talk about their complaint system in the aspect of that? Please feel free.
I would just like to add that we are required by the state, and it's very prescriptive on how we need to respond back to not only providers but members related to the complaint process. We have many different ways in Humana to get that complaint into the organization. Like like you said, David, you can come through the provider relations representative, you can come through the care coach. We have a website, we have a mailbox, we have a call center. There's many different areas that you can come in and register that complaint. We are obligated to respond to you timely. We research it holistically, not only from the aspect of what your complaint is, but how it impacts your members, our members, and how we can get to the root of what the cause is so that it's not singular in focus, but it's really giving us a deep dive in many of the root causes that we may see so that we can really address those and correct those so that it doesn't become a prevailing issue with our network.
Thank you. If I could just say very quickly, Sunshine has a dedicated provider number that you can call. And I actually brought someone, if you have a claims or billing issue, Katrina Hill right here, second table in the front. And she can share that number with you as well. But she'll make sure that your issues are followed up on and that you know who to contact. Thank you.
Thank you so much. And Anne, with Humana, didn't you bring some documents that if you're interested in getting, is it tip sheet? What is it?
So I brought a provider quick reference guide, and Gina Catal, who is the manager of provider contracting, she is sitting over there with her hand up, and if you'd like to pick one up, it goes through our procurement, our recruitment process, our claims process, claims billing guidelines, credentialing information, our provider call line, our grievance line for members. So quite a bit of information that will help you that you can share with not only your members but your staff.
Thank you. Arlene, are you good? Anything to add?
I also have quick reference guides.
Did you bring them with you?
Yes, I do.
Where are they?
Right here. So
Right there, okay.
come say hi and I'll give you one.
Okay. So do you like the idea, I'd like to hear from you because we developed and designed this program for you. Do you think the idea of having a Medicaid managed care guide that sort of encapsulates some of what we've talked about today, like a written document, would that be helpful to you?
Yep, absolutely.
You like that idea? Kind of a universal kind of guide. And yes, did I hear yes? Okay. And would you guys be willing to work with FALA perhaps on developing it? Kind of work with me on okay, I've given myself a nice big job. So I think, if memory serves, I think that we have brought this in for a landing. I would like everyone just to thank our panelists. I've learned so much just working with each of you. So thank you so much you're all very busy individuals, and you've invested your time with us today, and I really appreciate that. And I know the audience does too. And you guys, thank you so much.